Welcome to the deep dive. Today, we're embarking on a journey into, well, one of the most fundamental yet really intricate structures of the human body, the vertebral column.
That's right.
We've got a stack of fascinating insights from your sources, and our mission today is to distill them into clear, memorable knowledge, especially for those of you just starting out on your medical journey. Think of this as your essential roadmap, maybe, to understanding the spine.
Absolutely. The vertebral column is uh, quite literally the central pillar of our existence. It affects everything from how we move to, well, how our nerves function.
Everything.
We'll be connecting the dots between its gross anatomy, its characteristic features, and the common clinical issues you'll definitely encounter. We'll even throw in some helpful anchors, metaphors, and a few thought-provoking questions along the way. We'll come back to the answers as we go.
Okay, sounds great. Let's truly unpack this incredible structure then. Your sources describe the vertebral column as the central pillar of the body, yeah,
Huh.
and part of the axial skeleton. What makes it so crucial? I mean, I've always sort of pictured it as fairly rigid, but you called it a flexible skyscraper earlier?
That's a great way to put it, actually.
Yeah.
It is quite the multitasker, and that flexible skyscraper analogy, well, it works because it highlights both its support and its dynamic nature.
Okay.
It supports the skull, the shoulder girdle, or upper limbs, the whole thoracic cage, and it projects the body's weight all the way down to the pelvis and lower limbs.
Right.
But it's definitely not just a rigid beam. It's a highly dynamic structure, built from bones, intervertebral discs, IV discs, and ligaments.
Uh-huh.
Crucially, it provides these vital attachment points for bones and muscles, offers incredible shock absorption, and perhaps most importantly for you as future clinicians, it's a really robust protective conduit for the spinal cord.
Ah, okay. The spinal cord itself.
And the roots of the spinal nerves and the meninges too. It ensures the entire body gets segmentally innervated.
That is a lot of critical jobs, and it certainly moves in quite a few ways.
Indeed. Your sources highlight its impressive range of movements. Flexion and extension, that's bending forward and backward.
Yep.
Lateral flexion, so bending side to side. And rotation, twisting. So considering all those diverse movements, what do you think truly gives the vertebral column both its incredible flexibility and its fundamental strength? Keep that question brewing in your mind as we dive deeper.
That really frames the challenge, doesn't it? Flexibility and strength. Okay, let's talk about its overall composition then. How many vertebrae are we talking about in this skyscraper?
Well, we typically have 24 single discrete vertebrae, each one capable of individual movement,
24 single ones.
plus about 8 or 9 fused vertebrae down at the bottom. So breaking it down simply, 7 cervical C in the neck,
P7.
12 thoracic T in the chest,
Each 12.
5 lumbar L in the lower back,
L5.
then 5 fused sacral vertebrae, and finally 3 to 4 fused coccygeal vertebrae, which form your tailbone.
Right, the tailbone.
So you can easily remember the order as the CTLS-CO pattern.
CPLS-CO. Got it. And it's not just a straight column, is it? We have these very distinct natural curves.
Exactly. Think of it as an S-curve for strength and stability. It's quite elegant.
An S-curve.
Yeah. In a fetus, there's just a single C-shaped curvature, concave anteriorly. We call that kyphosis.
What's kyphosis? Okay.
And that's a primary curvature. It's maintained in the thoracic, sacral, and coccygeal regions throughout life.
Right.
Then in childhood, we develop secondary curvatures. These are called lordosis, and they're concave posteriorly.
Lordosis, like in the neck and lower back.
Precisely. The cervical curve develops when a baby starts lifting its head, and the lumbar curve when a child starts to walk.
B.
These natural curves are absolutely crucial because they distribute the body's weight really efficiently. They project it into the lower limbs along a line that passes centrally through them.
Ah, I see. It's for balance and shock absorption.
Exactly. It's an elegant solution.
Yeah.
And notice, too, how the vertebral bodies themselves, they get progressively bigger as you move down.
Oh, yeah. Why is that?
They're adapting perfectly to the increasing compression forces. More weight lower down needs bigger supports.
Makes sense?
And the sacrum, being fused, widened, and anteriorly concaved, well, it's perfectly designed to transmit the body's entire weight through the pelvis down to the legs.
Okay, now let's zoom in a bit. Let's get down to the individual building blocks. What does a typical vertebra look like, if there is such a thing?
Good question. Each vertebra is sort of like a miniature fortress, you could say, with several key components. Anteriorly, you have the vertebral body. That's the largest part, the main weight-bearing section.
The body, great.
Its articular surface is covered with hyaline cartilage, forming a strong, slightly movable joint in it, a symphysis, specifically designed for sustained weight-bearing, but with some flexibility.
Yeah.
And like we said, the size of these bodies increases as you go down.
Okay. And posteriorly.
Posteriorly, there's the vertebral arch. This is formed by the lamina
No.
that connects the transverse process to the spinous process.
Lamina.
And the pedicles, which connects the transverse process back to the body.
Pedicles. Okay. Arch, lamina, pedicles. And in the middle.
In the middle of all this, the vertebral foramen,
Mhm.
that creates a protected passageway for the spinal cord and the meninges.
Got it. And these vertebrae aren't just, stacked like blocks. They interlock with several processes. You mentioned those. They seem to guide the movement.
That's right, yeah. There are 7 distinct processes on each vertebral arch.
7. Wow.
Yep. One spinous process pointing straight back.
The bumpy bit you feel.
Exactly. 2 transverse processes, one on each side. And then 2 superior articular processes and 2 inferior articular processes.
Okay, superior and inferior articular processes.
These articular processes form the facet joints, or zygapophyseal joints. These are synovial joints lined with cartilage.
Like tiny knee joints in your back.
Sort of. And their interlocking design is critical. It prevents vertebrae from slipping forward, and their orientation, how they're angled, fundamentally determines how much flexion and rotation is possible in that specific part of the spine.
So the shape dictates the movement.
Precisely. And these joints are further strengthened by the ligamentum flavum, which we'll get to. Oh, and the thoracic vertebrae also have special costal facets for rib attachments.
Ribs, right. Okay. Beyond the bones, your sources really highlight the intervertebral discs. They sound like pretty important shock absorbers.
They are absolutely vital. Think of an IV disc as a gel-filled donut is a pretty good analogy.
A donut, okay.
They account for about 25% of the length of the entire vertebral column, and they have a very high water content, which is what keeps them turgid and springy.
But that changes with age, you said.
Yeah, unfortunately, that water content gradually decreases as we get older.
Yeah.
Now, each disc has 2 main regions. The nucleus pulposus. That's the jelly in our donut.
Nucleus pulposus. The jelly.
This is the central gelatinous bit, actually remnant of the notochord from development. It has a high osmotic pressure, acts like a hydraulic cushion, and its size changes a bit throughout the day and with age. Interestingly, it's pretty central in an infant, but it shifts more peculiarly in an adult.
Shifts back. Huh. Okay, and the outer part, the dough.
The annulus fibrosus, that's the dough. This is the peripheral, highly complex outer layer. It's made of these layers, lamellae, of annular bands arranged in varying directions, crisscrossing.
Like plywood.
Kind of like biological plywood, yeah.
Yeah.
Very strong. And it's avascular and aneral.
Meaning no blood supply, no nerves.
Exactly. Which is crucial clinically because it means discs have a very limited capacity for self-repair once they're damaged.
Yeah.
That really impacts how we manage disc problems long term.
Right. No easy fix.
And this annulus completely surrounds the nucleus pulposus. It's the major shock absorber, incredibly resilient under compression. In fact, it's often stronger than the bone of the vertebral body itself.
Stronger than the bone. Wow. So the discs provide that essential flexibility and cushion. But what about stability? That brings us back to our earlier question. What gives the column flexibility and strength? I'm guessing it's not just the bones and discs. There must be something else holding it all together.
Ah, yes. This is where it gets really interesting. This is where ligaments come in. They act like the spine's internal guy wires and springs.
Guy wires and springs. I like that.
They provide crucial stability. They allow controlled movement while preventing excessive stress. We have these major ligaments running parallel to the vertebral bodies. First, the anterior longitudinal ligament, the AL.
AL, anterior.
This is the stronger, broader one. Runs along the front of the vertebral bodies. Its main job, prevent hyperextension like bending too far backward.
Okay, stops you falling backward too far.
Exactly. Then there's the posterior longitudinal ligament, the PLL. This one's narrower, weaker. Runs along the back of the vertebral bodies, inside the vertebral canal. It helps prevent hyperflexion, bending too far forward, and significantly, it helps prevent the IV disc from prolapsing directly backward.
Okay, so weaker, but still important for discs. So, given those roles, what's the key clinical takeaway for a student about these ligaments? How they protect us, maybe where they fail?
Well, a key insight is how the PLL's relative weakness on the sides, posterolaterally, makes that the most common spot for disc herniation.
So it bulges out sideways and back.
Exactly. That's a critical point when you're assessing back pain. It's like a weak spot in the disc's donut. Conversely, the strong AL at the front protects against catastrophic hyperextension, making pure hyperextension injuries, while possible, less common than those posterolateral disc issues.
Got it. Weak spot posterolaterally due to the PLL. Okay, beyond those two major ones, the AL and PLL, I remember there are other critical ligaments adding more stability.
Absolutely, yeah. These additional ligaments are also essential for keeping everything together. First, the ligamentum flavum.
Ligamentum flavum. Sounds yellow.
It is. Flavum means yellow. It's got a high content of elastic fibers. It connects the laminae of adjacent vertebrae.
Okay.
It's stretched during flexion when you bend forward, and it helps strengthen those facet joints we mentioned.
Yeah.
It acts like a spring, helping pull the spine back to neutral.
Like an elastic band.
Sort of, yeah.
Oh.
Then you have the interspinous ligaments. These are relatively weak. They unite the spinous processes along their adjacent borders, and they fuse with the supraspinous ligament behind them.
Interspinous, between the spines.
Yeah, the supraspinous ligaments. These are strong, cord-like bands of fibrous tissue. They run right along the tips of adjacent spinous processes. They get really tight when you flex forward, especially in the lumbar region.
Supraspinous on top of the spines. Stronger one.
Right. And finally, the ligamentum nuchae. This is only found in the cervical region, the neck.
Nuchae.
It's a triangular, sheet-like ligament. Attaches to the base of the skull, the external occipital protuberance, and the spinous processes of all the cervical vertebrae. It plays a big role in maintaining that secondary curve in the neck and supporting the head. It's also a major attachment site for big neck and trunk muscles like the trapezius.
Wow. So thinking back to our initial question, flexibility, A and D strength, it really does seem like this incredibly complex dance, doesn't it? Bones for structure, discs for cushion, and then all these ligaments, the guy wires and springs tying it all together.
It's truly a marvel of biomechanical engineering, allowing controlled movement while preventing excessive stress.
It really is.
Precisely. It's the integrated function of all these parts, the S-curves, the discs, the intricate web of ligaments that gives that perfect balance.
Okay. Now that we've graphed the general structure, let's explore how it varies. We need to talk regions. Let's start at the top, the cervical spine.
Right. While all vertebrae share that basic plan, they are definitely tailored for function. The typical cervical vertebrae, C3 to C6, are sometimes characterized as C for carotid and crazy.
Carotid and crazy. Okay. Why?
Well, carotid because they have a unique feature, a transverse foramen in their transverse processes. This acts as a conduit for the vertebral artery and vein going up to the brain, except C7, it usually doesn't have the artery.
Ah, the vertebral artery goes through the bone itself. Wow.
Yep, and crazy, partly because of the atypical ones, C1 and C2, which we'll get to, but also because the typical ones are distinct. They're the smallest of the discrete vertebrae. They often have a bifid or forked spinous process.
Forked, okay.
And a large triangular vertebral foramen for the spinal cord. Their bodies are small, sort of dome-shaped, with these upward-facing lips called uncinate processes.
Uncinate processes,
Right.
okay. And the clinical relevance here?
Well, the cervical spine's unique structure, high mobility, those special C1, C2 joints, the transverse foramina protecting the vertebral arteries. It means any trauma here, even if it seems minor, demands really careful attention. You've got a dual risk to the spinal cord and to the brain's blood supply.
Right. High mobility equals vulnerability.
Exactly. Its mobility is its strength, but also its critical vulnerability.
And then there are those crazy atypical ones you mentioned, C1 and C2, designed for specific head movements.
Absolutely. First is C1, the atlas, named because it bears the weight of the head, the skull.
Like Atlas holding the world.
Precisely. It articulates directly with the skull.
Yeah.
And crucially, it has eno-body and eno-spinous process. It's basically a ring of bone. It's designed primarily for head nodding, the yes motion.
Okay, Atlas for yes.
Then C2, the axis. It features this unique projection sticking upwards called the odontoid process, or the dens.
The dens.
This dens projects up and articulates with the inside of C1, the atlas. This joint allows for head rotation, the new motion.
Axis for no.
Yeah. And a useful way to remember the order. Yes comes before axis. No, just like atlas comes before axis.
Ha! I like that. Atlas before axis, yes before no. What about C7?
C7. It doesn't have a special name, but it's a bit different. It usually lacks that bifid spinous process, and its spinous process is really prominent, long. It's called the vertebral prominence. You can usually feel it easily at the base of your neck.
The bumpy bit at the bottom of the neck.
Got it.
Okay, speaking of cervical things, nerves. We have 7 cervical vertebrae, but 8 pairs of cervical spinal nerves. How does that work? That always trips me up.
That's a great point, and yeah, classic question for anyone learning spine anatomy. It seems weird, right?
Yeah.
So the rule is, cervical spinal nerves generally emerge above their corresponding numbered vertebra. C1 nerve above C1 vertebra, C2 above C2, and so on, up to C7 nerve emerging above the C7 vertebra.
Okay. So where does C8 come from?
C8 is the exception. It emerges below the C7 vertebra, between C7 and T1.
Ah,
And then from T1 downwards, all the spinal nerves consistently exit below their numbered vertebra. T1 nerve below T1, T2 below T2, etc.
okay. So C1, C7 exit above, C8 exits below C7, and then T1 downwards exit below. Got it finally. Ew. All right. What are some common cervical spine injuries we might see, given its unique mobility?
Well, that high mobility means lower inherent stability, as we said. So it's prone to injuries like whiplash, which involves both hyperextension and hyperflexion forces, often from car accident.
Whiplash, right.
Specific fractures we often see include Jefferson's fracture, that's a fracture of C1, the atlas, often from an axial load, like falling head first, maybe diving into a shallow pool and hitting your head.
Ouch. Does that damage the cord?
It typically causes significant neck pain, but often, surprisingly, no immediate neural signs because the ring tends to burst outwards, actually widening the canal sometimes. But it's very unstable.
Okay. And the other one?
The hangman's fracture. This is a fracture through the posterior arch, the pedicles, of C2, the axis. It's caused by severe hyperextension of the head on the neck.
It's like in a hanging.
Exactly, hence the grim name. It was famously associated with judicial hangings. This is definitely considered an unstable fracture.
Right. Okay. Moving down from the neck. We hit the thoracic region. What defines these 12 vertebrae, especially with their connection to the rib cage?
The 12 thoracic vertebrae are really uniquely characterized by their costal facets. These are special smooth spots on the sides of the vertebral body and also on the transverse processes.
Costal facets for the ribs.
Precisely. Costal means rib. These facets are exactly where the ribs articulate. The head of the rib attaches to the body, usually spanning 2 vertebrae, and the rib tubercle attaches to the transverse process.
So they lock into the vertebrae.
Yeah. And they have a relatively small circular vertebral foramen. This whole region, being locked into the rib cage, gains significant stability. But the trade-off is a much more limited range of motion compared to the neck or the lower back.
Stability over flexibility there.
Okay.
Below the ribs, we enter the lumbar spine, often the site of heavy weight bearing and, well, a lot of common complaints, right? How are these vertebrae adapted for that load?
The 5 lumbar vertebrae are absolutely designed for heavy lifting. They are the largest and most robust of all the discrete vertebrae, very large kidney bean-shaped bodies, and thick, blunt, really robust spinous processes that point pretty much straight posteriorly. You can see they don't have transverse foramina like the cervicals or costal facets like the thoracics. That makes them easy to distinguish.
No extra holes or facets.
Right. Their vertebral foramina are smallish and triangular, but still quite spacious enough for the Cauda Equina, the nerve roots descending there.
Okay. And finally, anchoring the whole column, forming that strong base, the fused sacrum and coccyx. What's key about these last segments?
The sacrum is usually 5 fused vertebrae. It articulates laterally with the iliac bones of the pelvis at the sacroiliac joints, forming this powerful wedge-shaped base.
Fused for strength.
Absolutely. It's incredibly strong, designed to transmit the entire upper body's weight through the pelvic girdle down to the lower limbs. The coccygis is typically 3 or 4 fused vertebrae. It's that small triangular bone, basically a remnant of a tail.
That little tailbone.
Yeah. And while it's small, it's clinically relevant because it's pretty easily fractured during falls, especially falling onto your backside, or sometimes during childbirth. It can be quite painful.
Right. Okay, so we've covered the ideal structure. Amazing piece of engineering. But of course, things can go wrong. Let's shift focus now to some common abnormalities and injuries you'll see in practice, starting with abnormal curvatures.
Right. We talked about the normal S-curve, the physiological kyphosis, and lordosis. But these can become exaggerated or pathological, leading to significant clinical issues.
Like what?
Well, lordosis, that inward curve in the lumbar and cervical regions, can become exaggerated. You see this sometimes during pregnancy or with obesity, or maybe due to a large central body mass pulling the spine forward.
Like a swayback appearance.
Exactly. Then there's senile kyphosis. This is an excessive forward curvature of the upper spine, specifically an exaggerated thoracic kyphosis, more than 45 degrees, concave anteriorly. It's very common as people age, often as those secondary curvatures start to diminish, leading to that classic hunchback look.
Okay. What about side-to-side curves?
That's scoliosis, an abnormal lateral or sideways curvature of the spine. It's often accompanied by some vertebral rotation as well.
What causes that?
It can be primary, so congenital, born with it, or idiopathic, meaning we don't know the cause. And that can happen at any age, often adolescence. Or it can be secondary due to something else like a neuromuscular disease affecting the muscles supporting the spine.
Does it cause problems beyond appearance?
While it's often primarily cosmetic, yeah, severe cases can significantly decrease lung capacity because it distorts the rib cage.
Oh,
And then you can get kyphoscoliosis.
a mix of both.
Exactly. A combination of kyphosis and scoliosis. This is often caused by asymmetric weakening of the paraspinal muscles, maybe from something like spinal muscular dystrophy. This can really lead to reduced lung capacity, pulmonary hypertension, and even spinal cord compression in severe cases.
Wow. Okay. Now, one of the most common things people hear about is a slipped disc or a prolapse disc. What's actually happening there? It's not really slipping, is it?
That's right, yeah. Slip disc is a bit of a misnomer. It doesn't really slip out of place. It's actually a herniation of that soft, jelly-like center, the nucleus pulposus.
The jelly squeezing out of the donut.
Exactly. And it's really a spectrum of degeneration. It progresses through distinct stages. First, disc degeneration, just chemical changes, maybe age-related wear, weakening the disc structure, but no outward bulge yet.
Yeah.
Second, prolapse. The nucleus starts to bulge outwards a bit, maybe impinging slightly into the spinal canal. The annulus is still intact, though.
So contained.
Third, extrusion. Now, the nucleus actually breaks through the annulus fibrosus, but the extruded material is still connected to the main part of the disc.
Okay, broken through but attached.
Fourth, sequestration. This is where the nucleus breaks completely through the annulus and a piece breaks off, lying completely free outside the disc space within the spinal canal.
A free fragment. That sounds problematic.
It can be, yeah.
Yep.
Where do these usually happen, and what are the classic symptoms a patient might come in with?
Most commonly, these herniations occur at L4-L5 or L5-S1 in the lumbar region. That's where there's a lot of load and movement. Or sometimes in the cervical region. L45, L5-S1, lower back.
Yep. And because that posterior longitudinal ligament, the PLL, runs strongly down the middle, the herniation usually occurs posterolaterally, sideways and backwards.
Yeah, into that weak spot you mentioned.
Exactly. And this causes compression of the spinal nerve roots exiting at or below that level. This leads to what we call radiculopathy.
Radiculopathy, yeah.
Root problems.
Right, root pathology. Symptoms typically include lower motor neuron weakness, meaning the nerve signal isn't reaching the muscle effectively, causing weakness or even flaccid paralysis, along with dermatomal sensory signs like tingling, numbness, or shooting pain in specific skin areas supplied by that compressed nerve root.
Pins and needles or pain down the leg.
Yeah, exactly. And myotomal muscle weakness, affecting the power of specific muscles supplied by that particular nerve root. The exact symptoms depend heavily on the level, the direction of herniation, and how quickly it happened. Okay, what if it goes straight back?
If it herniates directly posteriorly, which is less common because of the PLL, it can cause direct spinal cord compression, and that is a neurosurgical emergency.
Right. How do we test for a potential lumbar disc herniation clinically?
A very common physical exam maneuver is the sciatic stretch test, also known as the straight leg raise.
Straight leg raise. Okay.
Yeah. With the patient lying flat on their back, you passively lift their legs straight up, keeping the knee extended. If doing this causes pain that radiates down the posterior thigh or buttock, especially below the knee, that's considered a positive test. It strongly suggests irritation of the sciatic nerve, often from a lumbar disc prolapse pinching one of its roots, like L5 or S1.
Okay, pain on lifting the straight leg. Now, here's a test for us then. If a disc herniates at L4, L5 in that typical posterolateral position, which nerve root is most likely getting compressed? You mentioned this earlier. Let's see if we remember. We'll revisit that answer in just a moment.
Good question. Let's hold that thought.
Okay. What if the herniation is really massive? You mentioned emergencies.
That's when we get into the territory of Cauda Equina Syndrome, or CES. This is a true neurosurgical emergency.
Cauda equina, the horse's tail nerves.
Exactly. Those nerve roots descending below the end of the spinal cord. CES involves a massive posterior disc herniation. Often it's bilateral, usually at L4, L5, or L5-S1, and it affects multiple sacral nerve roots that supply the perineum, the bladder, and the bowel sphincters.
Okay, that sounds serious. What are the signs?
You absolutely need to know the red flags for CES. These are crucial for spotting it quickly. They include bilateral sciatica, so leg pain on both sides. Severe or progressive bilateral neurological deficit in the legs, weakness or numbness getting worse on both sides.
Both legs affected.
Yeah. New onset incontinence or retention of urine or feces. That's a big one.
Bladder and bowel problems.
Saddle anesthesia or paresthesia, numbness, or tingling specifically in the perineum, the area that would contact a saddle. That points to S2, S4 nerve root involvement.
Saddle area numbness.
Erectile dysfunction, which can be a newer symptom, and reduced anal tone on examination. Any of these warrant immediate investigation and likely surgical referral.
Wow. Definitely red flags to remember. Okay, so back to our question. A posterolateral herniation at L4, L5 typically compresses which nerve root?
It typically compresses the L5 traversing nerve root.
The L5 nerve root, and why is it the traversing root?
Precisely, you got it. The key reason is anatomy. At most lumbar levels, the nerve root that exits the spinal canal at that level, so the L4 root at L4, L5, usually exits above the disc base, relatively protected in the foramen. But the nerve root that needs to travel down across the back of the disc base to exit below its own numbered vertebra, so the L5 root crossing the L4, L5 disc to exit at the L5S1 foramen, is the one vulnerable to posterolateral herniations at the level above.
Ah, so L5 has to cross the danger zone at L4, L5 to get out lower down. Makes sense. Okay, what about other age-related issues beyond acute disc herniations?
Well, as we age, that nucleus pulposus, the jelly center, can dehydrate. It loses water content. This decreases the overall height of the intervertebral disc.
The discs shrink a bit.
Yeah, and this shrinking alters the load stresses on the adjacent structures, particularly the edges of the vertebral bodies. This can lead to reactive marginal osteophytosis.
Osteophytes. Bone spurs.
Exactly. Bone spurs forming on the outer side of the joint margins. Also, the decreased disc height puts more stress on those facet joints we talked about earlier.
The little joints at the back?
Yep, leading to osteoarthritis in those joints. And since those synovial facet joints are innervated by the meningeal branch of the spinal nerve, this osteoarthritis can cause significant back pain.
So wear and tear on the discs leads to wear and tear on the facet joints too.
Okay. And in the cervical region specifically, what does degeneration look like there?
That brings us to cervical spondylosis, which is basically just degenerative osteoarthritis of the intervertebral joints and the facet joints in the cervical spine.
Spondylosis means degeneration. Pretty much, yeah. Degenerative changes in the spine. It can lead to radiculopathy in the arms, causing those dermatomal sensory symptoms like paresthesia, numbness, pain, and myotomal motor weakness in the arms or hands.
Similar to lumbar radiculopathy, but in the arms?
Exactly. Or, less commonly, but more seriously, if there's significant narrowing of the spinal canal due to bone spurs or disc bulging, it can cause pressure on the spinal cord itself. That's called myelopathy.
Myelopathy. Cord involvement.
Right. And that causes different symptoms.
Yeah.
Global weakness, problems with gait and balance, clumsiness, and even loss of bladder and bowel control in severe cases.
Okay, radiculopathy is root, myelopathy is cord. Got it. Are there other types of spinal fractures we should know about besides those specific cervical ones?
Yes, wedge compression fractures are quite common, especially in the thoracic and lumbar spine.
Wedge compression.
Yeah, they typically result from vertical compression combined with some flexion force, like falling onto your buttocks from a height, or a significant impact. The front part of the vertebral body collapses more than the back part, creating a wedge shape.
Ah, okay. Are they stable?
Most are considered stable, meaning they don't immediately threaten the spinal cord,
Phew.
but they can cause the spine to curve forward, lose height, and cause pain. Importantly, they are sometimes pathological.
Meaning caused by something else.
Right. They can occur with less force if the bone is already weakened by conditions like osteoporosis, significant trauma, obviously, or critically, spinal metastases, cancer spreading to the...
Spinal metastases. So right, that brings us back to red flags. What are the critical warning signs, the other set of red flags, that would make us suspect something serious like a spinal tumor or infection when a patient presents with back pain? Not the Cauda Equina ones, but for cancer or infection.
That's an excellent question, yeah, because recognizing these early is paramount. Your sources list several common primary cancers that frequently metastasize to bone, including the spine, breast, bronchial, which is lung cancer, kidney, prostate, thyroid, and melanoma. So if a patient has a history of these or presents with certain symptoms, you need to think about these red flags for potential cancer or infection in the spine.
Okay, what are they?
A gradual onset of symptoms rather than a sudden injury, severe, unremitting pain, pain that persists even when they're lying down, not relieved by rest.
Pain even at rest.
Aching night pain that actually disturbs their sleep, pain that's aggravated by straining, like coughing or sneezing. Any significant thoracic pain, because benign mechanical back pain is less common there.
Thoracic pain is suspicious.
Yeah. Localized spinal tenderness when you palpate. No symptomatic improvement after, say, 4 to 6 weeks of standard conservative therapy. And, of course, unexplained weight loss. Any of these really warrant further investigation.
Got it. Really important red flags to keep in mind. Okay, let's finish with a crucial clinical procedure you'll definitely encounter, The lumbar puncture, or LP. Where is it performed, and why is that specific location so critical for safety?
Right, the lumbar puncture or spinal tap. It's performed typically at the L3, L4, or L4, L5 interspace, so between the spinous processes of L3 and L4, or L4 and L5.
L34 or L45, why there?
The reason for this specific location is absolutely critical for patient safety. In adults, the spinal cord itself usually tapers down and that endpoint is called the conus medullaris around the level of the L1 vertebra, sometimes L2.
The cord ends at L1, L2?
Yeah. Below that level, the spinal canal doesn't contain the solid spinal cord anymore. Instead, it contains the descending spinal nerve roots, which look like a horse's tail, hence the name Cauda Equina.
The horse's tail nerves.
Exactly. So performing the LP down at L34 or L45 ensures you're inserting the needle into the region containing only these mobile spinal nerve roots floating in the cerebrospinal fluid, the CSF. This significantly lowers the chance of accidentally damaging the spinal cord itself.
Much safer below the end of the cord. Makes sense. So the needle goes in. What's the path it takes to actually reach the CSF in that subarachnoid space? What layers does it go through?
Okay, imagine passing the needle from the skin on the back, going deeper towards the spinal canal. It has to traverse several distinct layers. There's a common mnemonic that can help you remember the order. Sulfitas.
Sulfitas. Okay, what does that stand for?
Let's break it down. 1, skin. 2, subcutaneous tissue, the fatty layer. 3, supraspinous ligament, if you're perfectly midline. 4, interspinous ligament, between the spinous processes. 5, ligamentum flavum, that elastic yellow ligament.
Okay, skin, subcutaneous, supraspinous, interspinous, ligamentum flavum. Then what?
Then you enter the epidural space, which contains epidural fat and veins.
Epidural space.
After that, you puncture the dura mater, the tough outer meningeal layer.
Europe.
Then the arachnoid mater, the thinner middle layer.
Arachnoid.
And finally, you enter the subarachnoid space, and that's where the CSF is. So esophagus gets you there.
Skin, subcutaneous, supraspinous, interspinous, ligamentum flavum, epidural space, dura, arachnoid, subarachnoid space.
Got it. Wow. What a deep dive into the vertebral column. We've really covered a lot. Everything from the overarching structure, individual vertebrae, the discs and ligaments, those crucial clinical issues like disc prolapse and red flags, and even the lumbar puncture. Yeah, and this foundation is absolutely critical for your future clinical practice. Understanding the spine isn't just about, memorizing anatomical terms. It's about appreciating this marvel of biomechanical engineering that supports us, protects vital structures, and enables pretty much every movement and sensation in the body. It's truly where strength meets vulnerability.
So what does this all mean for you, listening? It means the spine is just a master class in balancing strength, flexibility, and protection. The next time you see someone standing tall, or maybe bending to tie their shoes, or even just sitting upright, think about that incredible interplay of bones, discs, ligaments, and nerves that make every single movement possible. And maybe ponder this. How does maintaining good posture truly impact the long-term health of this vital structure beyond just looking good in the short term? Something to think about until our next deep dive.